I hope you can see my screen now, right?
Yes, I can.
Hi, Amir. Thanks for joining.
Yeah, thanks for inviting me. It was a kind of a short notice, but I'm happy to do it.
So I think we are in time, and it's 8 p.m. in India. Let me start the program. This is a part of monthly educational webinar we do for mostly for the Indian Interventional Pulmonology group, and we try to get speakers who are experienced in doing peripheral navigation biopsies using different platforms. As we all know, peripheral pulmonary nodules is always challenging when you don't have enough guidance, and most of the times you feel like you are in the lesion, but actually you're not. So to solve these problems, like in the last 5 years, we have a lot of new technologies coming to Indian scenario. Like we only have navigation bronchoscopy from bronchus, that's the lung point, and we are happy to say we did the first cone beam CT scan yesterday, and we too had a lot of problems. I know it's a lot of learning curve. So today our topic is on lung vision, a CM-based AI tomography. The topic will be delivered by Dr. Roshen Mathew, who is a board-certified intervention pulmonologist who directs the intervention pulmonary services at West Virginia University, uh, Camden Clark Medical Center, and he's actually involved with Fellows Educational Committee with the AABIP and actively reviews and publishes in the field of IP. And as moderators now today, we have Dr. Amir Abramovich. He is the Director of Interventional Pulmonary Unit at Carmel. Both of the universities sound the same. And he's from Israel. And we see him a lot doing peripheral navigation biopsies using thin scopes and cone beam CT scans on the LinkedIn. He's very active on the social media platforms, putting up his cases. We welcome you, Dr. Amir, and also joining us, Dr. Kedar Hibare from India. Like he's an intervention pulmonologist from Narayana Hrudayalaya, Bangalore, and he's one of the renowned pulmonary interventionists in the country. And let me take you through this. Yashoda Hospitals, the largest intervention pulmonary group in the country. And also we recently started this Academy of Bronchoscopy where we try to train people in new technologies from experts. And also, I would like to share, yesterday we performed the first cone beam CT scan in two of our patients with a lot of difficulties, I would say. We had a lot of challenges during this procedure, very steep learning curve, and I think we need a lot more experience in getting right into the nodules there. And we also know that most of the times these are the challenges we face. Like every nodule is like, unless until there is a bronchus sign, most of the nodules looks like an illusion. So to overcome this, Roshan will help us with the new platform that is lung vision on how to reach those nodules in a simpler way than the cone beam CT. And I would like to hand over the lecture to Dr. Roshan.
Okay, let me just share my screen. All right, you guys can see my screen?
Yes.
All right, let's just start. Okay, so this won't be a really long talk. It's just going to be very short and more of a discussion. So Hari already introduced me. I'm Roshen Mathew. I know Amir, I know Kedar, and I know Hari too. So it's just going to be a short, very informal, just exchange of experiences. So this body vision is just another navigational platform. So what I'm going to try to do is just kind of, it's been with my hospital just a few months, because of some learning curves and other things in the system that we needed to iron out. So I'm just going to tell you what my experiences is with it. And I've dealt with many other navigation systems before and played with the robot, not too much, a little bit. So how is this different from that? And is this really just another navigation platform without much anything added to it extra, or is it something more than that? We'll see. So I really don't have any kind of conflicts of interest, no disclosures, nothing of that sort. All right, so the body vision, like I told you, is it's a lung nodule navigation system used for peripheral lung nodule biopsy. So why is it a slightly different? Because it offers intraoperative CT-like imaging. What they usually do is a CM-based tomosynthesis, actually, to give you images during the procedure itself, so that you can see where exactly you're in different planes of the nodule. And does this really increase your diagnostic yield? I mean, I think yes, we'll see. So this is just a skip through literature. We don't really have to go in the depth of it. Despite what different navigation systems in process, different robots that has come along the field, like Hari said, our yields in peripheral lung nodule haven't really changed much. Starting from the Rayleigh-Liebers and the benefit study to the Navigate study, it's always been around like the 74 to 75. And we used to think, is this really good enough for our patients? Because, we know that our colleagues in interventional radiology, by just doing CT-guided biopsy, still has a yield somewhere around 90 plus, okay? And fortunately or not, with all these different systems in place that we have to go after nodules to get an early diagnosis, the survival rate for lung cancer is also really bad. In the 5-hour survival rate is about 18 to 19%. It hasn't really changed too much. So why is that gap there? People are dying too much, and we have a lot of new technologies still come along, and we're still not able to improve our yield. That's, I think, because of two main things. Because one, we have a CT scan, we navigate to a lesion, or we think a lesion is what we call a virtual target. Okay, and then secondly, we may see the virtual target, with the Rayleigh-Liebers, or we may not see it because of atelectasis or something, or we might, mistake something like atelectasis for the nodule itself. So those are some things. And then the second thing is also we biopsy mostly blind or semi-blind. We use fluoro, we use the Rayleigh-Liebers, but we really don't have live biopsying of the lesion, meaning the tool, whatever we're using, going into the lesion, seeing it exactly. So that's why that all the navigation systems we have really doesn't give us that big of a yield. Okay, now things are changing. So we know, I don't have to really speak to you too much about virtual. We all know what really that is. So virtual target is a target that the navigation system tells you that, hey, this is the target you're going after. And the actual target might be still maybe a few centimeters away sometimes, and that is called the CT to body divergence. Why does that happen? Because the lung is a very dynamic organ. And in the lower lobes of the lung, the CT to body divergence is much higher than the upper lobes. And not that it's any easier in the upper lobes, but because of that CT to body divergence, I've seen in my other, I won't mention names, but other navigation systems that I've used before, I navigate to the virtual nodule. I'm right there in it. So my localization is almost 95% plus. I bring in the C arm, and then you see that the ball bounces away. So it's just that navigation, there's already a CT to body divergence, and then some amount of challenges with the navigation systems. So, and then, so all these small things really add up to making the nodule further away and more difficult for us to really get to. Now, what you see, like I told you, our interventional radiology colleagues see the nodule or see the lesion and go in and direct guidance, see the tool going into the lesion. So they have much higher yields than us. So now things are changing in the peripheral nodule front with cone beam CT, like Hari said, and the yields have gone up because, again, you see the tool going into the lesion, okay? So what is this body vision's intraoperative CT-like imaging that they claim is? So it is not really CT-like, it is CT-like imaging, it's not CT imaging. So it's a CM-based tomosynthesis. So what you see on this side is just a CT scan, and then this is what they have recreated, Okay, and the most important thing is you see your tool or catheter, whatever it is, going into the lesion in different planes, meaning in AP view, in left anterior oblique and right anterior oblique view, so that you know in different planes that your lesion or the trajectory of your tool is where it really needs to be. Okay, so these are some images that I've taken from different people who do this a lot. And so what you see on this side is preoperative CT scan, and what you see on this is the tomosynthesis imaging that you see that is recreated by body vision. So you can see the nodule. So how do they really get to this? We'll go into that details a little bit later. So then what they really do is, they mark that lesion on the fluoroscopy, and you can really, you navigate to that part, just like any other navigation system. You put your tool in there, but you get the tool confirmation in 3 different planes, and then you can really readjust your biopsy tool to go to that lesion. So it's kind of a live imaging. And then after that, they usually have some algorithms which they use to really recreate and make sure that you have a 3D image of your tool going into that particular lesion. Now, this is a CT on one side, and on the other side, you can see that tool is kind of going. This is something that the body vision created by tomosynthesis. So you can see that lesion is seated in that, the tool is seated in that lesion, which is what we really want. Okay, it's not that we have reached the virtual target. We need to have that confidence that we are really biopsying what we really need to do. So this gives us that confidence, which was really not there in prior navigation systems, I think. And this is, again, a 3D imaging of a lesion, again, from one of the other practitioners here that I've taken. So showing that the tool is going really, it's a 3D view. I'll show some of my images later of the tool really protruding into the lesion and biopsying it. Now, what you see here, this is the lesion in question that they're going after, and these are some of the airways. The purple airway that you see is the airway that you plan. So I think this is a navigation system which actually uses your experience as a bronchoscopist much more than the other navigation systems. For the reason that, you know your airways, this is probably in the anterior or the superior segment, wherever it is, and you try to maneuver around that small airways, and then try to identify it in different planes so that you make sure that the lesion is really where it needs to be and the tool is where it has to go. Now, how is this different? The workflow is really not a lot different in terms of other navigation systems. Meaning you have a preoperative CT, you have the planning that you've done on your navigation platform. You identify a virtual target on the navigation platform that you're using. You may or may not reach it by navigating to it and have visual confirmation or non-visual confirmation, or just with the radial EBUS, and then you do the biopsy. But here, the only slight difference is that, you plan as a virtual target in the beginning, and then during the process of the biopsy itself, you're going after an actual target in terms of you're seeing it on fluoro in different planes. And then once you reach that spot, you scan your fluoroscopy in different planes and make sure that the tomosynthesis image that you're getting is really along the pathway that it needs to be. So, and eventually you get that tool and lesion confirmation, which I think trumps it, and which gives it a much larger edge over the navigation system in trying to get more diagnostic yields. So, I mean, these are some of the slides I've taken from body vision itself to just make it easier. But really, in my operating room, there's not much of footprint. You have your C-arm, which can be anything. I use one of the older C-arms, and and even the newer C-arms that I have works great with it. The only thing that they have is a board which goes under the patient, a lung vision tablet, just like an iPad, and it's not hooked up to anything. It connects wirelessly to the body box, the the platform, which itself is like a box on wheels, and it can be put in a remote corner of the room. You won't even know that's in the room. So it really doesn't take much footprint in an already crammed OR with a lot of other things lying around. So that's a key thing, that you still are not hampered by lack of space with new equipments coming into the OR. Now, so these are some data from some of the other people who do this a lot here, like Pritchett, Kyle Hogarth in Chicago. And, you know, they just, so they have all the tools, meaning they have a robotic bronchoscope, they have manual bronchoscopes, they have the cone beam CTs. So, and this is just some data comparing how they use the body vision. And they overall had like what, 84% to yield, which is very conservative, with just using a manual bronchoscope. And with the robotic bronchoscope, and just using the robotic bronchoscope and the body vision for the tool and lesion confirmation, the diagnostic yields were anywhere between 85 to 90 and above. So that's great. You know, that's kind of along the line of where our IR colleagues' diagnosis yield is. And, you know, as we all know, for us, it's important because we can simultaneously do staging also right after you have the diagnosis. So that's a big plus for us as interventional pulmonologists. So this is just some of the, again, some images that I've borrowed from Pritchett. So showing a cone beam CT going into a really small lesion. And this is the tomosynthesis image of the same. So it's not a perfect image, but it is good enough for us to see where we need to go and where we need to go. So I think that's a big plus, you know, comparing a 700 to 800 million cone beam CT versus, you know, just a simple C-arm that you have, and a $200,000 equipment, that's the navigation platform. I think that's a big difference in terms of costs. So it gives you fairly good images, I think so. So this is just a rough video that I shot, which was much longer. I cut it short quite a lot. And just we can just kind of go through it. There are some workflows which I have not been able to take here because of some restrictions in my hospital. So basically, once you load the image, the plan into the tablet, you bring your C-arm in, you take 3 shots at the AP view, you mark your carina, and then you do a LAO and RAO shot. And then some people do also what we call as a local registration, meaning at the same time before the start of the procedure. So how that is done is you do a breath hold with anesthesia with a APO valve for about, I would say, about 10 to 15 seconds with normal tidal volumes, and the patient is already paralyzed. And then you actually do a local registration to the nodule or the lesion that you're going after. And then you start the navigation process. And then once you kind of reach where you need to be, and then you do a local registration or confirmation again using your C-arm, and it constantly updates it on the fluoroscopy screen. So that part of it, I've not been really able to add to the video because of some restrictions in my hospital. But this will just kind of show you basically what it.
So this is a video demonstrating the setup of the body vision navigation system. So this is the main tablet with the CD player in it. And you have very close to it the body vision box, which usually is plugged in. You can stay away from the main OR field.
So this is just the planning of the system. So there's a nodule on the right upper lobe there. So just like any other navigation system, it's you mark a lesion, and then you mark which part of the lung it is, and then you do a volumetric analysis on it by marking the borders. So that's basically the kind of the flow for most navigation systems. Then it segments the airway, it shows you what airways are there, and you really can mark few spots to show where you need to really go and have kind of a pathway, which again is a virtual pathway. Or the The virtual bronchoscopy itself, I haven't found it really to be much useful. It really is not much useful in my opinion. So this is just a local registration of the nodule itself. After that, it'll show you that on the fluoroscopy screen that you see, and you put your tools out and then just biopsy it. You can check it from different planes when you biopsy. I sometimes will go to a LAO, RAO, and kind of see if I'm along the pathway. That's that purple thing that they're going to the lesion, and then really biopsy it. So this is just one of my cases in which, you reach the nodule itself, and you can see that the catheter is kind of aiming along the pathway to that nodule in the right upper lobe in the posterior part. And again, under fluoroscopy, you're in the lesion, I check it out, and then I get a 3D confirmation with the platform itself, and see that the catheter or the biopsy tool is projecting right at the nodule itself where I need to be. So it gives you, I think, decent imaging. It's not like cone beam, but it's really, I think, very, very decent.
So this is
okay, so what I haven't done a lot of cases with it. It's like I told you, I started off and then we had some pushback from administration and things slowed down. So I've done like 15 cases so far with it. And most of my nodules have been between 1.5 to 2.5 centimeters. There was one 3-centimeter nodule. And my smallest nodule was about 9 millimeters. So the localization was about 93 to 95%. It was really, really good. One nodule that I think on my last case that I did, I really couldn't localize the tool in different planes because there was really no any kind of airway going in. And if you want, you can say I chickened out in terms of trying to create a pathway to really go there. So I think my yield is, anywhere on the 80% mark, considering the fact that, it's really not a lot of cases that I've done so far. But you should think that any kind of navigation system or any kind of new modality that you use, I think even people with a good amount of experience with navigating different systems, you usually will have a threshold for about 10 to 15 cases for your team and yourself to be very comfortable by using the whole platform. So considering the learning curve, I think I'm much happy with the yield that I really have. Now that's where I want to stop, but I'm sure this will really go up going forward. So the nodules that I did not have a diagnosis, one was about a 9 millimeter nodule in the lingula, which they got a segmentectomy. It was adenocarcinoma of the lung. And the other one was a right middle lobe nodule, again it was a little over 1 centimeter, I think 1.1 centimeter, something like that. Again, was very difficult to navigate to. Even though the localization was good, each time I would put my biopsy tool would get deflect too much. So there are some challenges which I'm working on. So that again was another adenocarcinoma when they did a segmentectomy on it. So one other nodule was a benign nodule, is still being watched. So those are my numbers are very small, but the experience that I've had so far, I do really like it. Now, there are pros and cons to any kind of system that we use. So I think the cons is that, just as for any other navigation system, the right middle lobe, lingula, posterior lesions usually are slightly challenging to reach. Not that it cannot be reached. I've had fair good experiences with it, except for 1 or 2 cases. Now, less than 8 millimeter lesions, if you don't have that much of a solid body to the nodule, the CM-based tomosynthesis imaging, I think, is not the best because it's so faint, and your best bet during that time would be to use a cone beam CT. But if you have solid nodule, 1 centimeter and above, it gives you very, very decent imaging. The navigation system as such is, I think, it's mediocre. But the most important thing is it shows you that your tool or your catheter or whatever you're using is really in the lesion itself. So that I think is priceless. And and if you have to really use a tool in lesion, a navigation system with tracking tip tools, the cost of the disposables significantly goes up. So the one other thing that is also, it's fluoroscopy based system. So you have to have some degree of training for your staff, especially your rad techs who is going to help you. They need to know when to slow the system down, to take good pictures, to get good imaging. It's really after about 4 or 5 cases, it's not really a difficult thing to learn for the rad techs or your staff. But some degree of training, a little more than the other navigation systems, is necessary, because they are equally actively involved in helping you out during the process. Unlike other navigation systems where you just shoot a fluoroscopy image and you're looking at it, fluoro on, fluoro off. That's not the deal here. So your rad tech really has to communicate with you and understand the process of what's going on. And in terms of anesthesia, also, again, not much of a big deal. You tell your anesthesia people that, hey, I want this patient paralyzed or with a full tidal volume breath hold. They will just do it for you. It's so easy for them. I don't think it's much of a, so there's some degree of training that you need to do with your staff. Now, what are the pros? So a cone beam has significant amount of radiation exposure compared to just plain fluoro. So I think the radiation exposure is much less. The big selling point for me, besides just the tool and lesion, is that it's a very small footprint. You don't really need to leave the room or try to fight for a cone beam CT room to get the room for doing your cases. And it can be performed with any C-arm based, even if it's old C-arm, it'll work with it. And I think it's very, very cost effective. We'll go a little bit later on regarding the costs of the disposables. So you basically can, there's no limitation in using any tools. You can, the cross usability of the system is great. So that's why many of my friends here who do this a lot, they integrate it into the robot, they integrate it into different systems, and they have really good, they really don't have any kind of problems integrating it with different systems. So you don't really have to use the catheter. I think later Amir can pitch in on that. You really don't have to use that catheter if you have a thin scope, and you just, so basically whatever you have in your toolbox, you can use it. So that's I think is a big plus, because it brings down your disposable costs quite a lot. And for me, it was very important because it was a program that I was building from scratch. And for me, the cost of the disposables was a big deal, because I can't justify that I'm going to spend a lot of money on a disposable and have a negative money from each procedure that I do. So I can't justify that to the administration. So this is just actually just thing I took from Amir's side. So I think this is something we all need to think always. You can have 100 gear in your system. You can have new things that come along, but learning to push your limits with whatever you have is key in building a successful program. And you still can get testing your limits, and knowing your limitations is also very, very important. Okay, that's basically a few slides that I have. Okay, thank you.
Thank you, Roshan. Like now, we will go on for the discussion part. I like Dr. Amir and Dr. Kedar to join the discussion. If you can stop sharing the screen, like.
Yeah, let me stop.
Can I go ahead, Hari? Would that be okay?
Yeah.
Hey, Kedar, how are you, man?
I'm good. I'm good, Roshan. So let me get straight to the couple of points that I really want to raise. What I like about the body vision is that whether it is cone beam CT or whether it is robotics or whether it is body vision, they are moving from an era of 2D to 3D, And what also I understood today very, very significantly is technology is moving from trying to get us to the virtual to the real. Amir, it was very humbling to actually see your post on trying to use lesser and lesser gear, or using the gear that we already have. Our bronchoscopy suites are already filled and overflowing. And I hope Body Vision will try to help us in trying to reduce the kind of burden that we have. Let me cut across and get straight to the question. One of the important things that Body Vision promises is old equipment integration. And that's really great for us because in India, we're always looking at costs. But one interesting point about Body Vision is about artificial intelligence. And I also saw earlier in the day today on LinkedIn, Ahmed, you've posted something about artificial intelligence as well. I want to understand what is the artificial intelligence part of Body Vision. So can you just shed some light on what really is the system going to help us from the artificial intelligence perspective?
So you can hear me, Kedar?
Yes, I can.
Yeah. So I think initially I had the same question too when I started off, in the first generations of this thing. I was thinking, what is really this artificial intelligence thing that they're talking about? But what I understood is that what they really meant was the evolution of the system. So each cases we do, they upload all these things to their cloud or whatever process it is. Wow. And they have a system of algorithms that they keep on really evolving as time comes on. So because I thought this was going to be like something very, very either it's just a marketing gimmick or something different that we don't understand. But I asked them, but that is what it is. So from their first generation, when I was actually watching the system for a few years, and to what it's come down to now, meaning that you can really see the tool, whatever you're using, meaning it's a forceps or anything in the lesion, that's a big evolution. So that evolution of that algorithm and everything is, I think that's what they mean by the artificial intelligence. There's really nothing more to it.
You're basically suggesting that this is like how Elon Musk is developing his technology in Tesla. So with every mile that the car goes, you're uploading that onto a big database, and that database is understanding more and more of what we're trying to do. Okay.
Yeah. So the initial generations, they were understanding the airway was much difficult for the system itself, but they have come quite a long way.
Ahmed, you have anything to add to what Roshen has already said on the artificial intelligence part? Because I've seen so many more cases that you've done on this platform.
Well, I think the AI part of the system is like any other system that is relying on AI, which is collecting a lot of data, big data. Every case that is done with the system all over the world is uploaded to some kind of big database, and I guess that it is the algorithm. There are certain algorithms in the system. Okay, I'm not a code writer, but probably in the system there is some kind of algorithms that takes all these data and learns from that, and and enables the system to work more properly, more accurately. For example, I've seen the difference between the CABT imaging and the AI imaging. And in the AI imaging, you can see, for example, GGO lesions much more clearly, that you are able to see them using just CABT. So in future system, I believe that you are able to switch between, once you do the spin, you can look at it either in the AI mode or the CABT mode. I understand, I don't have a personal experiment with that, but I communicate a lot with the people that develop the systems, because, as you know, it's an Israeli company, and they spend a lot of time in my bronze suite, and I learn a lot from them. I want to believe that they learn a lot from me, and in the conversation, I understand that in the future you will be able to switch between the AI and the CABT to see your lesion more clearly. And of course, the system itself learns how to pinpoint the lesion during the bronchoscopy more accurately. For example, I had a version of the system when you had to also mark the borders of the ribs in the beginning of the procedure, and lately I was upgraded with a program that it is not already needed. So I guess this is also a further development that came from looking at all the procedures that that was done all over the world.
Amir, I have one question for you. Like you have cone beam CT and you have lung vision both. So how do we choose between the cases? Like when do you prefer to use lung vision or cone beam? The anesthesia protocols remain the same. So what's your take on this?
Well, for example, well, in the beginning, I think people have to understand why I chose the body vision system, because I was not looking for a navigation system. Okay. I first began to navigate the periphery with thin and ultra thin bronchoscopes with the 4 and the 3 millimeter scopes. And then I had the problem that I went after nodules that I really didn't see on simple fluoroscopy. So I started to use cone beam CT, and with the cone beam CT, I was able to mark and see on fluoroscopy, on augmented fluoroscopy, everything. But as we all know, cone beam CT is a very demanded tool, and I was not able to use it as much as I wanted. So I was looking for a system that will be able to simulate a cone beam CT, that will be a cone beam CT-like system that I will be able to use in my own bronch suite. I was not looking for a navigation system, and I personally do not look at body vision system as a navigation system, but as a real-time intra-procedural imaging system that are able to give me accurately augmented fluoroscopy image and tooling lesion image, and lately the 3D reconstruction image. Now, why I don't use the lung vision for every case? Why I still using the cone beam CT? The problem with the lung vision system that you have to synchronize between the system and the patient and the CT that you uploaded to the system, because in cone beam CT, the table and the C-arm knows all the time the position of each one. It's a whole system. When you use the lung vision system, you have the C-arm, you have the table, and you have the lung vision system, and it's 3 different systems that has to be synchronized. Okay, and to do that, you do all the Carina registration, you do the CABT around the lesion, and the bottleneck of the system is the ability of the doctor to actually identify the nodule after you do the CABT, and to tell the system, this is the nodule, this is what I want to get to. If you're not able to do it, the system is worth nothing. But if you are able to do it, from my experience, because I began with cone beam CT, if you are able to pinpoint accurately the nodule, the lung vision gives me the same accuracy as cone beam CT. I can rely it exactly as I was working on cone beam CT. Now, where is the problem? The problem is both with GGO lesions, which has a very low surface radio opacity. In those lesions, sometimes I have hard, even if they like 3 centimeter, very soft GGO lesions. Sometimes with the CABT, I have trouble to identify it. And in these cases, I prefer to use the cone beam CT. And in very small nodules that are close to the midlines. One of the problem of the lung visual system that it doesn't give you an axial view of the reconstruction. When you can, for example, cone beam CT, you see an axial view, so no nodule can hide. But the CABT gives you some kind of a spin around the longitudinal axis of the patient. So it's a combination of the coronal and sagittal view. And if you have a very small nodule around 10 millimeters and less, that is very close to the midline, especially to the lung hilum, then you can confuse between this and some kind of cross section of a blood vessel of bronchus, and then it's a very hard. You have a very hard time to pinpoint the nodule to the system, and in instances that I am not able to do it, very confident, I cannot rely on the system. So to summarize, I use the cone beam CT in very small nodules that are close to the midline, close to the lung hilum, and in very delicate GGO lesions.
Okay, then like if you have a patient, like you're seeing the lesion on cone beam in all the planes, but still when you put your 3 mm bronchoscope there, you're not able to pass your radial probe into the lesion. So how do you access those lesions? Like, do you have it through like a needle? And how do you direct those needles?
Well, I usually do not work with catheters, okay, with extended working channels. Okay, my system of getting to peripheral pulmonary nodules is actually working with thin and ultra thin bronchoscopes. So it's pretty much like working with a robot, except that you have to navigate yourself. But the big advantage that you have always vision in the periphery, and this is very important. And sometimes I know for advance that I will not be able to get to see the lesion bronchially, and I'm navigating to the lesion using the augmented cone beam or lung vision image. When I get there, if I'm not seeing the lesion endobronchially, I can just use the RIBAS, the radial ultrasound, to try and figure out where is the lesion or the nodule relative to the wall of the bronchus. If I get an eccentric view, then I put a needle through the wall in that place and then put the RIBAS again through the hole to see if I get a concentric image. And if I get it, then I put in a forceps or a 1.1 cryoprobe, and I had a pretty good success with it. The problem is if you have to go cross country for a long distance, if you cannot actually see the eccentric RIBAS image, in that case, I have to rely on the 3D reconstruction, either of the lung vision or the cone beam CT, to understand if I am behind, above, below the lesion, and try to put a needle in and then do a spin. It can be a spin to see if I have my lesion, my needle in the lesion. Okay, this is my method of doing that. It works, I think, in most cases, but some cases I cannot get into in this method. I mean, one of the shortcomings of the system is that, unlike the robot, you are not getting a virtual image of the nodule relative to a three-dimensional image of the nodule related to the tip of your tool or tip of your bronchoscope. Okay, so if if you looked at the videos of the virtual bronchoscopy of the robot, you can simply aim your tool to the virtual image, and hopefully hope that there was not too much of a CT2-body divergence, that the actual nodule is not where the virtual nodule is.
And Roshan, like before we do a cone beam, we do isocenter the patient using the cone beam platform. Like for lung vision, how do we do that? It's all manual or?
So you know, when you initially place the patient itself on the board, that's something you have to really check on, and then you bring your fluoro arm, and then you can really, when you mark the carina, you can actually kind of get it towards the center. And that's all there's to it. Really nothing more that we do additionally to, and the key thing is the board has to be where it needs to be, just below the shoulder or just to the level of the shoulder. And most of the time when we don't get that done properly is when we run into problems. So we make sure that the board is correctly placed, and then the patient is really paralyzed. At least for me, we do it under all paralysis. And then so that the carina itself is right at the dead center. Do you do it any other different, Amir?
Well, you have to do two basic spins. One is to synchronize the carina with the CT that the system got, and then you get instructions from the system how to move the C-arm three-dimensionally, or the table. I usually move the table, not the C-arm, in order that the lesion will be in the center of the C-arm spin. And then you do the breath hold and spin around the lesion, and you get the CABT, you mark it, and you're done. You get the augmented flow. If you want to do, and if you think that you are there and you don't get a rebus image, okay, and then you can do another spin to check if there was any CT2-body divergence. And a lot of times there is, especially in lower lobes. And of course, each time you want to demonstrate tooling lesion, okay, you have to do another spin. Like in the cone beam CT, it's exactly the same. Once you get the virtual image, the remaining of the bronchoscopy is just like I'm using the cone beam CT. The same way. But there is one advantage with the lung vision, that if you are with the tip of your needle or the tip of your rebus or the tip of the bronchoscope in the lesion, you can do a spin when you are in the room without leaving the room. I can hold my 3mm scope exactly the same position that I want without leaving the room. With the cone beam CT, you have to fix the bronchoscope somehow, and there is a lot of strange methods of doing that. And then you have to leave the room. And sometimes when you leave the room, the tip of the bronchoscope deflects, and then you cannot actually see where you were actually have been. And another thing that you mentioned, one of the shortcomings of the system, or your experience, is catheter tip deflection. When you are using the ultra thing, the thin scopes, you don't have a problem with that, because you can actually compensate on your way, on the fly, again into the position of the lesion, and you can actually even sample different areas in the lesion and around the lesion to minimize your chance of missing it if there was a little bit of CT2-body divergence.
Right.
Yeah. And of course, cost. There is no more cost except your tools. Yeah.
No more cost there.
Yeah.
One last quick question I have, Roshan, this is for you. I'm going to put you on a little bit of a tight spot. The question really is, do you think that body vision trumps over robot, or do you think it's complementary? I mean, I know it's quite unfair to compare two technologies completely different, but having toyed around and played with both of them, I think it's a question to ask.
I think
I mean, without cost considerations, because I know nobody in India can buy both of them.
Yeah. So don't quote me on this. The robotic people hate, but basically, I think the robot, at least with the yields it has now, without cone beam or any other imaging, it's just a bronchoscope holder. You know, it's a bronchoscope holder that is very, very stable. That's it. You know, so if I have another bronchoscope holder that will hold things in place, I don't need the robot because I know how to get to different places. You know, so the robot really doesn't give me now, and the reach of the robot, you can simulate that, like Amir said, with 3mm scope. It'll get you where you need to go, you know. So I don't see anything additional that I gain from the robot if it's going to give me 75% yield without using any kind of live imaging to give me that this is tool in lesion. So I think that upper edge that body vision has is because of that live imaging. It's not the navigation system. The navigation system is really not much of a big thing with it. I like Amir mentioned, just to piggyback on it, it's just the ability to see where you need to be and the ability to see that your tool is really where it has to go. So that is the bigger edge. So that's why some of my friends here who are combining the robot have now ergonomics. You can sit in a chair and play a video game and you still will be able to see it. And then just, it's not as tedious as doing a C-arm and get much higher yields. So it's just a combining of process. But again, you know, for them, all the toys are available. You know, for a place like me where I'm very, very budget conscious on what I need to really put and really invest in, that's not an option. So if you have all the tools, combining it, great.
If I can just add,
you know that you are also budget conscious.
I'm very budget conscious, my friend.
if I can just add something,
yes, sir.
Every navigation system, even the robots, the actual image that you have, it can be a green ball, it can be a blue ball, it can be a pink ball. It's a virtual image, okay? It does not compensate for CT to body divergence, and it cannot give you a tool in lesion confirmation. The only systems that can give you, as I know, tool in lesion confirmation is cone beam CT and lung vision. And this is exactly the systems that all the places that use robots tends to use it with cone beam CT. And now there are, I know, a few places in the US that are combining robots with lung vision, okay? And the reason is that every navigation system, including the 2 robots that we have in the market today, cannot compensate, or the virtual image that they give you, it's a virtual image based on some kind of primary planning based on CT that you entered into the robot or navigation system. Once you anesthetize the patient, we know that along the first 30 minutes, the lesion may move. It can move up to 2 centimeters in the upper lobe and 4 centimeters in the lower lobe, and I've seen it, okay? So it definitely, answering your question, is complementary. It's not one instead of the other, it's one that will complement the other, okay? And what I tell all the time that to lung vision system, you have to develop your system not as a navigation system. You have to close the gap as much as you can between lung vision system and cone beam CT. Because once it will happen, and they are very close to there, you will be able to do your cases in your own bone suite using your own C-arm in above 85% of the cases. And even if we look further for ablation, okay, I think that if you are able to actually identify the lesion in CABT, the rest of your procedure is exactly like CABT if you're looking at accuracy and tool and lesion confirmation. So it's a complementary systems.
And one last question, Amir, before we wind up the session. See, while doing my case, I had marked 3 lesions. Like in one of the lesion, to do a repeat spin to confirm the radial EBUS position, my scope was there. Okay, I fixed my scope to the mediflex arm, but it was in a flex position. And how do you fix this this arm to flex the bronchoscope? And also, how do you fix the radial EBUS? What tools are you using now?
I'm just fixing the bronchoscope with the tape to some kind of improvised arm that I did. I don't use the mediflex. I don't have the mediflex. And in my experience, if you are using a 3 millimeter scope and your nodule is far enough in the periphery, usually it is well wedged in a way that it will not move in the tip. Okay, so usually I don't fix the lever of the bronchoscope. Although I guess that if you want, there are ways to do it. But again, this is another advantage of the lung vision system, that you can continue and hold the scope exactly the same way you are holding it without the need to leave the room. So that's that.
I think that's it for today. And thank you, Roshen and Amir Kedar, for joining our session. So
Thank you, Hadi.
yeah, if you have
Thank you for inviting me.
Thank you.
Yeah, thanks for having me on the show.